Registration is open for the 2022 AMSN convention. Join us September 29th through October 2nd, 2022 in San Antonio, Texas, or virtually. Attendees will have the opportunity to earn up to 38 NCPD contact hours, explore education sessions across 6 tracks, and make new connections. Head to convention.amsn.org to register. That's convention, convention.amsn.org.
This is Alyssa.
This is Caroline.
And this is Chelsea. Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud medical surgical nurses, just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Hello, guys, and welcome to another episode of Med Surg Moments. This is Parker and Caroline. Alyssa couldn't join us this week because she has a migraine, so let's wish her a speedy recovery. Just some personal updates. My fire alarm needs a new battery, and I have not been a good adult this week, so it needs to get replaced soon. I'll call maintenance about that tomorrow. Personal update number 2, my puppy Ziggy will be 7 months on the 24th, and she's getting so big. She's so cute. She's learning how to sit and do, all sorts of neat stuff. So definitely a highlight in my life. And of course, work and school are always there, but it's nice to come home to a puppy and be showered with lots of hugs and love. And I don't get met with protests when I want to just grab her up and hug her and kiss her. So Caroline, what's going on with you?
Hi, everyone. Hi, Parker. Alyssa, hope you feel better soon. Well, puppies grow into dogs. And of course, if you're a regular listener to these podcasts, you'll know that I have my dog in the background, Fletcher, who is worse than a child. As soon as he hears his name or I get onto the podcast, he has to be verbal. So I do apologize if he suddenly breaks in. The other big update is that the Ashman family are on the move. We've had the opportunity to live in Tampa, Florida for the last 5 years, but have decided to move back to what we call home, not England home, but Georgia home. And by the time you're listening to this episode, I hope that I'm somewhat settled in my new location and still be coming to you, but just from a different part of the country. So we're very excited. We're sad in many ways that it didn't work out like we had hoped, but we know that being surrounded by our family, as we call them, things will be a lot easier for us. So that's the big news in the Ashman camp.
Congratulations, Caroline, on the move. You have to be like me and get a breed that doesn't bark. So I have Ziggy is a pit bull. And she rarely barks. I think I've heard her bark maybe like once or twice since I've had her. So.
Oh, he's settling down now by my feet. Maybe we'll be good. All right. What are we going to talk about today, Parker? What's our topic?
Well, our topic for today is care of the trauma patient. So I wonder how many trauma nurses we have out there that are listening. Trauma ICU, Med Surg trauma patients who are kind of a lower tier as far as acuity, but still has some of the implications that we're going to be talking about today.
Well, I'm interested to hear what your thoughts are on this. My experience with trauma patients is quite limited. So how would a medical surgical nurse tackle a trauma patient if they're not on a dedicated trauma unit? Is there such a thing as trauma step down, or enlighten me? And what are your biggest challenges with these patients? How do they differ from regular med surg patients?
So I actually work on a Med Surg trauma unit. So we have a trauma ICU, we have trauma step down, and then we also have Med Surg trauma, which is pretty interesting. It's nice having that cushion, knowing that if you do need to escalate your patient level of care, that you can. But usually if they're alpha trauma, they'll start off in the trauma ICU. So if someone gets into a motor vehicular crash, if someone is a victim of a gunshot wound, burns, that's something else that we see, depending on the severity. But most of our patients usually start off at the trauma ICU. Then they graduate to the step down, and then they come to us usually when they're getting closer to discharge, whether that be to a SNF, rehab, or home. Trauma also engulfs ground level falls. I don't think a lot of people realize that, especially in the elderly, are considered still trauma patients because they usually end up with fractures of some sort. So it's interesting having all these different kinds of trauma patients, people that come in with different experiences, et cetera. I think a lot of people don't take into consideration the emotional care that you have to give these patients, especially if it's something like a gunshot wound victim or a motor vehicular crash victim, or even I've had patients that have been the victims of domestic violence with burns. So it's a lot of emotional work that you have to bring to the table with these patients. Typically, like every shift change, you go in and the patient starts to talk to you about what happened to them, whether that be a motor vehicular crash or taking care of patients who have been hit head on by drunk drivers, the repercussions of someone else's actions that have been completely out of their control. So it's definitely a lot of different kind of emotional labor that I wasn't expecting.
Yeah.
I'm a travel nurse, so I think any of the travel nurses can relate to the experience of having to do those like 1.1 million modules before you start a new assignment. But that's definitely something that isn't talked about, is like the emotional labor, emotional support that you have to give these patients.
I never even considered the emotional aspects of what you do. And have you ever been put in a situation, or is this a possibility, where somebody shares something that needs you to bring in law enforcement because they're giving evidence, or they're sharing some piece of the story that will be helpful if we're trying to find the perpetrator? I never even considered that. Have you ever been in that kind of a situation?
I kind of have, but I was towards the end of the situation. So I had a patient that was a gunshot wound victim, shot in the chest randomly, didn't know like how it happened or who it was that shot the person or anything. There was obviously police involvement for that. But when I received his file, because he had an extensive stay, if you can imagine,
Yeah. Wow.
having to be resuscitated and all that stuff.
Right.
And by the
Right.
time he got to me, it was more managing that person for discharge. When I got his file, there was like a police card on top of the file. He was definitely at alpha trauma when he first got to the ICU. I'm pretty sure that they had heavier police involvement.
Is there like a top 3 list of the most unique needs of trauma patients that are on a med surg unit, whether it be med surg trauma or what you just described previously? What advice would you give to a med surg nurse that's looking to step up their game and move into this area?
Yeah, it's definitely a different kind of care. Before this, I had never worked with gunshot wound victims or motor vehicular crash. At my old hospital, I consider it my home hospital, there was a dedicated like trauma ICU. There wasn't like a med surg trauma floor. My motor vehicular crash patients often come with rib fractures, T3 fractures, neck injuries. Had a patient who like completely obliterated his jaw. He was intoxicated and
Wow.
like he couldn't chew. So then speech had to get involved. Like just different kinds of pain from these car accidents. Freshly broken ribs is definitely something different that you encounter. And then I had a patient who had a mesenteric tear from motor vehicular crash. So having to get surgery on top of having broken ribs really sucked. Lots of different things, and so many things can go wrong.
Yeah. Yeah. Is there any protocol in your facility for patients that divulge information that relates to a crime? Have you ever been put in that situation where there's an ethical dilemma because of privacy issues to be considered?
I've actually never been put in that situation before. So many of them are alphas that I don't even have to worry about that. That's something that the trauma ICU probably sees a little bit more of. Med surg trauma is just a little different of a ball game.
So what about injuries, wound care, and what's the latest and greatest treatments that you see? Is there any kind of pattern there?
I see a lot of gunshot wound victims with extensive wound care. Usually ends up being wound vacs. That's something that a lot of med surg nurses already see on their floors from patients, depending on how extensive like a sacrodecubitus ulcer could be, stuff like that. But definitely lots of wound vacs.
Right.
Lots of burn wound consults, lots of wound care, actually.
What about the family? What about the children? How do you deal with loved ones when they see someone 30 minutes before they're driving around seemingly fine or whatever, and then all of a sudden this devastating injury? There's a huge emotional connection there. And I wonder, did you have counselors in these areas or someone to provide grief support?
Seen chaplains be consulted, and then sometimes social workers. If you read the notes, it's definitely for my patient that was hit head on by a drunk driver, seeing the notes of their family having to be contacted and them rushing to the hospital. Because if I got a call about my sister or my cousin or someone, a dear friend being hit by a drunk driver, I don't care how stable they are, I'm going to be freaked out,
Of course. And then let's think about this scenario, staffing as it is right now, people, med surg nurses with limited experiences. Is there anything unique about the treatment for, let's say, a gunshot wound with wound care protocols when a nurse who is really not that comfortable? Like if it was for me, for example, and they said, okay, we're short, you've got to be floated to this area. What would I need to know? It's kind of concerning for me that I would have a basic level of competence here beyond airway, breathing, and circulation, I guess.
Yeah, it really depends on the patient. For the patient that was shot in the chest, extensive wounds. And I was intimidated, not going to lie. Intimidated when I had to care for this patient.
I bet.
Two wound vacs, one across the chest, one on the abdomen, urostomy, colostomy. I mean, just all sorts of wounds pretty much everywhere.
Wow.
But, you go, you read the chart, you assess your patient. Those assessment skills can come in handy because you can know whether your patient is stable or not. Looking at the entire picture, looking at the vital signs, looking at the output from the wound vacs, assess your fluids. Is it sanguinous? Is it serosanguinous? Is it
right?
I mean, there's so many basic things you can do and then pull it all together to get the complete picture of your patient. Also, looking at your vital signs, trends, exercising that chart. But most importantly, don't be afraid to call the trauma doc on call. Some nurses are intimidated to call the on-call doc. I don't care what it's for. You're on call.
Yeah, great message.
For a reason.
Yeah, exactly.
I don't care if you're in bed at home. I'm going to call you if I need you. Also, utilizing your charge nurse if you get floated to a unit like that. And then, obviously, if you're not comfortable with the assignment, say so. Don't be afraid to say, hey, I have limited experience here. But for the most part, it's just like caring for any other patient with there's being some exceptions. But
Sure. My thoughts now are turning to family and friends, an unexpected trauma, crisis prevention intervention, CPI. What techniques are you familiar with, or would you recommend for managing families and friends that their behavior gets out of control because they are extremely emotional because of what they're seeing and what they're hearing with a loved one?
Again, usually by the time they get to me, they're a little bit more stable versus being on the trauma ICU or like the STBICU or somewhere like that. So I usually don't have to deal with those complex psychosocial problems.
Right.
I often do see on my end for the patients are depression. And I mean severe depression because a lot of them do receive life-altering injuries or injuries that are extensive enough that they're not going to be at their baseline for 6 months to the next year. Some of them never again. So definitely having to be an advocate for my patient, saying this patient obviously not acting like themselves, having to advocate for that patient, but also now they have a disability. So having to advocate for their disability rights from that standpoint is also important too.
Right. There's the physical trauma and scars, and then there's the emotional trauma and scars. And even as the patient heals and recovers from something as devastating as a gunshot wound, it's good that they survive, of course, or burns, a disfigurement that comes with burns, or definitely post-traumatic stress for sure. And that's something that we don't see because in the short term, we're just dealing with the immediate problems that we can fix. And then these patients get discharged. Maybe they go to rehab for some kind of therapy along the way, but there's always that trigger that can then bring everything back emotionally for their overall health and wellness. Yeah. Kind of interesting the more I think about it. Certainly not a patient group I'm familiar with, but what you're saying is making me think about how we deal with not just the patients, but the family and friends as well.
And definitely something you have to consider. Techniques for handling that deeply depressed patient is to meet them where they are. I kind of like to acknowledge the depression. Like, I know you're having a tough time.
Right.
And I know that this probably doesn't seem much, but if you need anything, I'm here for you. Don't hesitate to call me, press your call button when you're in pain.
Right.
Kind of just getting down to their level and having compassion for them.
Of course, all those therapeutic interventions that we rarely have time for on a regular, busy, crazy med surg floor. Hopefully in this environment, there's a little better nurse-patient ratio that allows us to really get in touch with the therapeutic interventions and conversations to help the patient through this emotionally, for sure.
Unfortunately, we're in med surg, tele, trauma, and like regular med surg. So our ratio is still 6-1. So I have this gunshot wound victim or motor vehicular crash victim that's graduated from STIPIQ, graduated from trauma step down, and now to me, but I still have a 6-1 ratio. So that's definitely an issue with trying to stay on top of their pain and having other patients who are also sick as well is challenging. So
I'm sure. I'm sure.
Tough.
And you're having perhaps your own kind of emotional trauma because of everything that you're learning. You're going to come out much stronger. But in that moment, more power to you. I can only imagine. That sounds really pretty tough. I wonder how many of our listeners can relate to that. Wow.
For my ground level fall patients, they're not always elderly. Sometimes they're under 50. But I've gotten a lot of patients who are between the ages of 90 and 94. These past few weeks have been coming in with ground level falls that have been resulting in fractures. Some fare better than others. So I had a patient who had a ground level fall, was completely independent at home, but kept falling, fractured her, I think it was T3, got a kyphosis and was like walking around the next day. I mean, the tough as nails. So we have patients like that who are okay, but then you have patients who get hip fractures, not candidates for like an ORIF, and they're just bedbound forever. It really sucks for those patients who are used to being able to do everything for themselves. I've taken care of patients who haven't been like acutely trauma, but like quadriplegic patients who were gunshot wound victims who are like 9-10 years out and they've been bedbound for the past 9-10 years and just a really difficult situation. And then all the things that come with that, skin issues, severe wounds. And it's definitely something that can take a toll on that patient. Something else that I've seen too is a lot of unrestrained passengers. Had an unrestrained passenger that I took care of. She had a chest tube, broke her left clavicle. I mean, was just busted. It's really unfortunate to see that too as patients who were unrestrained passengers.
Let me ask you this then. What resources are available beyond the immediate nurse doctor team when you don't know what to do, when you're dealing with all of these unique issues that we never really even considered until we're talking about it right now? Who do we consult? Who do we go to? Who can help these patients find their way and their families find their way with the support system that they're going to need for the long haul?
I wish I could offer things outside of like case management and social work, but honestly, I don't know anything else other than that.
Gotcha.
I feel like I should, but even those resources I feel are so limited. Like our psych resources in the hospital and then like in the community as well, so limited. Like it's so hard to find help if you need it, in my personal opinion. Personally, for me, and this is just outside of trauma, what we're talking about, it took me a good minute to find a therapist I could trust. I can only imagine how that is for someone who's experienced an acute trauma and doesn't know where to go from there and doesn't have the resources to find a therapist or just someone they can talk to. So our psych services are lacking for sure.
Yeah, isn't that a shame? And I think that's probably not unique to your facility. It's unique across the country. Where I am currently, we actually have 2 dedicated behavioral health facilities, which is a tremendous resource to have. And it's by no means a full and complete resource, but at least they are there. And I think people forget sometimes when you're ready to be discharged physically, are you ready to be discharged psychologically? And what resources can we provide to make sure the patient is supported from the physiological and the psychological perspective? We perhaps forget about that unless you're dealing with it on a daily basis like you are. You know, wounds will heal, dressings can be changed, but how do you heal the emotional wounds? It's a lot, Parker.
Yeah, there's a lot to consider when you start digging. Well, you don't even have to really dig. You just read that person's chart and then look at their demeanor and
give me a nice, straightforward lap appy.
Yeah, seriously, right?
Wow. So what would be your closing thoughts?
My final words would be just to lead with compassion and expertise. Be a good nurse. Be a knowledgeable nurse. Be an involved nurse. For those 12 hours, be about your patient and their family. Be that comfort for them. I promise you guys, I've been doing this for 6 years. I've been under all sorts of conditions, and I know that compassion fatigue is a thing because it is. I find myself sometimes just short on patience. I do, but it literally takes 2 seconds to help someone feel better. It takes 2 seconds to kind of just put in that extra effort so the patients can know that you're there to support them.
Well, you bring things very nicely to a close because AMSN is all about compassionate, connected care. And if that doesn't speak to it in what we've just chatted about, I don't know what else is. So good discussion, lots to think about. And hopefully we've given our listeners something to think about as well.
We look forward to connecting with you all on our next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official Med Surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org. I'd also like to remind you to become a member or renew your membership at www.amsn.org. You'll receive lots of cool benefits and perks, such as discounted pricing on annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review, tell us how we're doing, and recommend Med Surg Moments wherever you get your podcasts to help us reach even more listeners. I also invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add #MedSurgMoments to your post. Simply enter AMSN in the search field on any of these social media platforms to connect with us.
The content within the Med Surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Chelsea.
I'm Alyssa.
And I'm Caroline. And always remember, Med Surg Moments is a moment in our lives, a moment in our Med Surg careers that make a huge difference.